kind of just a refresher on some different things. You know, over time we kind of get into a routine and we forget some of the basics. So we'll refresh on some of that and then talk a little bit about a few other things in regards to complications that we can possibly see, different assistive devices that we often use in TSU as well as in the ICU post-procedurally. And then we're also going to just touch on some very Impella specific removal procedure processes as well. So really quick, just talking about access whenever you're looking at any patient that's got any kind of access in place. It's really important that you actually are aware of the size of that access and any kind of variabilities that may be present. So sometimes whenever we would see patients in the ICU, they'll have different size sheets, obviously, as well as whether it's going to be venous or arterial. And then along those lines as well, there are times where we've often seen longer sheets. It's really good to know all of these things whenever you're getting a patient from the cath lab or any procedural area. Ask the questions before you get that patient, but then also make sure that you're just communicating that in handoff if the device is supposed to stay, if it's not, different things like that. On this slide, it just kind of talks a little bit about some different sizing that is present. It's used for a universal color coding system, so you can see 4 French all the way to 11. It should be, you know, consistent throughout, so you're able to kind of not have to ask those questions. But again, it's often good for us to make sure that we're all communicating that, because there are people who aren't aware of some of these different things. And then I did just mention a little bit about the difference between venous access versus arterial access in regards to when we hold pressure. We'll talk about it again in the actual process itself. But a good rule of thumb, I know our protocol technically says 15 to 20 minutes for arterial pressure and maybe 10 for venous. I kind of am a little bit more generous with that, only because, you know, there are times where these people are going to continue to have a little bit of oozing and bleeding, and so it's better to be safe than sorry. So for all intents and purposes, venous access typically around 15 minutes of pressure, and then arterial 25 to 30. And that's probably, like I said, overstating it just a bit, but just so we're kind of aware that, you know, those are going to bleed a little bit longer. For general sheath management, our protocol says that, you know, you want to check vital signs every 15 minutes for at least 4 times for that first hour. Again, every 30 minutes for 2, and then after that, you want to check vitals hourly. In the ICU, we're going to be checking them pretty frequently as it is. You should be really comfortable with checking these sites often. Your patient should know and expect that you're going to be doing that. The last thing we want to do is kind of make a patient uncomfortable and go in there and not tell them what we're doing, and then just go in at their groin area and be, you know, kind of mucking around. It's better just to go ahead and communicate that early on. Often in the ICU, we're so used to people being out of it or, you know, being sedated that we're not necessarily communicating with them, but just get into a regular practice anyway. Again, strict bed rest, head of bed less than 10 degrees. Sometimes we're going to have to use a neomobilizer for some limb restrictions. And then we're going to check an ACT at least 2 hours after they've arrived back from a procedural site. With that being said, you're checking these ACTs to continue to monitor them, but you should have a threshold that when the ACT falls below 170 that you're okay to pull. With that being said, you do have to have a provider telling you that they're wanting that device pulled. Oftentimes we're not wanting to keep it, but we have to be clear on communication. We're not just pulling, you know, accesses that we're supposed to be transducing instead, or different things like that. So again, checking your orders, communicating with the providers at hand, and making sure we're all on the same page with the plan there. Good morning. I'll go over a few other things and you'll have access to this on the video and everything, so I won't backtrack too much. So when we start talking about sheath removal and everything, some different supplies to have are listed on here. This, again, should all be pretty straightforward, pretty standard for all of us. Gloves, gauze, tegaderms, suture removal kit, at least a 10 cc syringe. It's good to have a CHG cleanser on hand, only for the simple fact that, you know, these accesses are considered a central access, and so we need to make sure we're cleaning that area before we remove to make sure that we're protecting the patient as well as possible. Other good ideas to have on hand would be O2 tubing as well as a continuous pulse ox. Additional supplies I've mentioned that I just kind of gotten the routine of using over time would be additional chucks or towels are often always a good option. I would always grab a thrombix. It's just a personal preference. It's something that I would often do whenever I would put the dressing on the very end. Betadine's an option if you're not using CHG, and then just out of practice, it's good to hold on to some IV fluids just in case. If someone, you're really concerned, you could always go ahead and have that on hand and ready to go. So again, the big thing that we want to do is make sure that the patient's completely aware of what this process looks like. It's a good rule of thumb to discuss this prior to even getting started with the procedure. You want to make sure that you're completely transparent about what they need to expect in regards to bed rest, in regards that this is going to be uncomfortable. If we are concerned that they're not going to be able to tolerate it well, there's often times where we can give some medicine to make patients more comfortable, but again, that needs to be pre-planned ahead of time. You don't want to be in the situation where you're holding pressure on a groin, having to yell out in the hallway, asking people for additional assistance for meds and different things like that in that time. And then it's also a good rule of thumb, I know that people get busy in the ICU and staffing's not ideal at times, but to notify your charge nurse that you're about to pull some of these lines is valuable. And if not your charge, then at least someone close by. Initially in these settings, it's ideal to have a nurse in the room with you, just because in the first initial minutes following sheath removal, you want to make sure you're checking vitals pretty frequently. You want to make sure that if you need assistance with medicines or additional fluids or anything like that, someone's there. But I would always get in the habit, especially whenever I was on nights, to just make sure there was at least somebody outside of who was going to be in my room that was aware of what was going on, watching my other patients, and available to check in if they needed it, because you need to expect to be in this room for a good 20 to 30 minutes. And then make sure you're documenting your most recent set of vitals. You're also going to want to try to, have those trended on your monitor and everything, so you can actually pull those over while you're in the actual process of removal. And then again, whenever you first start with sheath removal, make sure you're checking your blood pressure about every 2 minutes, and then you can transition to 5 or 10 after you've gotten everything set. But you want to make sure that they're not getting extremely hypotensive while you're in the midst of holding pressure. So whenever we're looking at patients who have sheaths in place, especially multiple, first thing we're wanting to do is pull the arterial first. So you're going to locate it versus the venous. Does anyone have any techniques on how they determine which one's arterial versus venous when your patient has more than one? Mm-hmm. Okay, good. So
the lateral one's arterial. Sometimes you don't know.
Mm-hmm.
Sometimes they're on top of each other, but if you don't know, just call the team.
Yeah.
The worst thing you can do is get confused, and sometimes the sheath is through and through, and so that's ideally the team or the physician or whoever put in the sheath communicates that, but sometimes they don't. So if something seems kind of funny or not right, just call, because that can also, obviously if it's through a vein into the artery, that's a different kind of sheath management.
And usually you won't know that, what I'm saying, because normally I don't think they knew the sheath if they felt like they went through and through.
No,
so if you see, if you see
it varies
blood
based on
when you pull a venous sheath, know that you might want to have somebody call somebody.
Yeah, it obviously varies.
It seems arterial, right?
Well, if they have TR, it'll be most top.
Yeah, so it's, but I don't know. I remember when I was in training, I just would first look at whichever one in the groin, whichever one's the lateral one, is the arterial sheath. But sometimes they're on top of each other, and you're like,
yeah.
I don't know.
Yeah, and again, like you said, don't hesitate to call. There's always going to be resources available to you. So rather than, just kind of pull and pray, this is a situation where it's important to be clear on the regardless. So with arterial sheaths, you want to aspirate at least 5 milliliters of blood from the sheath to be sure that it's not occluded. I typically don't flush this first. This is one that I'll just go ahead and draw back initially, and then after that, go ahead and turn your stopcock back to where you don't need to flush that blood back through or anything. That's fine. You're going to remove the dressing and suture, locate the pulse above the sheath. Typically about 2 or 3 finger widths is about the length or difference in where we're going to want to hold pressure for these, because you have to think about it, the end of that catheter is essentially where you're wanting to be able to hold the pressure, because that's where the actual artery would have been punctured. So it does us no good to hold below where the puncture site is. That patient can still have some blood develop. or pull together. So you're going to apply direct pressure above the sheath side, maintain manual pressure, like I said, for about 20 to 25 minutes on these arterial accesses. And then again, you want to make sure you're not completely occluding the pedal pulse for more than a minute. I've seen a few different techniques with this. If you have a second person in the room that can check their pulses for you, you know, another technique, it's not necessarily as tried and true, but you can throw an O2 pulse ox monitor on someone's toe and you can look for the waveform on the monitor. As long as you have a waveform, you have a pulse. If not, then you know you need to make sure you're backing off, but still able to be able to obtain hemostasis that way. So you kind of have to wax and wane on what that pressure looks like. It's better to go ahead and hold that more difficult pressure on the first ends of that, and then you can ease up as you're beginning to notice that there's no more blood coming or anything like that. Again, after hemostasis, you're going to want to clean the side again. You want to be gentle with this. You don't want to go and rub so hard that you're ending up irritating this and you're going to lose what you've stopped and have to hold pressure again. Place some gauze and a tegaderm. In this setting as well as whenever I go ahead and just throw in a thrombix, especially with an arterial access. Venous, I'm not necessarily as concerned, but I think it's just a good rule of practice to go ahead and throw on a thrombix. It's not going to hurt anything, but it certainly is going to help some things. So again, this just kind of goes over the technique for pulling, some holding pressure and different things like that. Obviously you can see some with these pictures, but it's like what we've talked about. We're going to hold pressure slightly over the access side itself. I personally like to hold high enough over that I can actually see the hole where we've went in. I don't like to cover that with gauze or anything, just because I want to be able to see if we're bleeding underneath my hand or underneath my pressure. That way I can make adjustments in real time. And again, if you're uncomfortable with sheath pulls, if you've had bad experiences in the past and you want extra help, if you need extra hands on board, there's nothing wrong with that. There's additional resources in the ICU always. So it's better to just be comfortable in a situation and know that it's being performed well, rather than, you know, being in an uncomfortable situation and getting into a stickier situation following.
Go back to that one time. I think that's a really important point. You know, when you have to think about when we stick a vessel, the deeper the groin, the higher up from the entry side of the sheath to the vessel. In really like skinny people with very shallow groins, you know, where we go into the vessel will be closer to where the sheath is. So a lot of mistakes that get made, in particular when we go to the floor in places, is people are holding where the sheath was and not where we stuck in the vessel. So you always do want to hold higher than where the sheath is coming out of the skin. And if it's a really deep groin, you may need to hold, you know, a fair bit higher. And that's usually where two hands are better than one hand in that situation.
All right, so venous access removal is going to be similar. So you're going to make sure you're locating where it's at. You're going to also aspirate 5 with it. The blood will be darker. You're going to apply pressure slightly below or at the sheath site with this one, and then you're going to hold pressure for about 15 minutes. You know, sometimes these people don't need pressure held that long, but a good rule of thumb is 10 to 15 at least. Again, you just kind of want to be sure that you're going to get the end result, and you're not going to come back in, you know, 10 minutes later after you've pulled this and see blood in the bed and different things like that. It's just better to go ahead and stay present and be aware, you know, of what that can look like, and just continue to hold. I know it's miserable to hold pressure, but it's better to do it on the front end than have to do it for later. So common adverse reactions, obviously bleeding, hypotension, which we've kind of touched on. A lot of that you'll see initially with removal. Bradycardia, you should typically have orders for atropine in place for any kind of sheath removal orders. For symptomatic bradycardia, just make sure that this is symptomatic, that the patient feels terrible, that, you know, they look bad, they may have some, you know, low blood pressure with that bradycardia and different things like that. Sometimes you'll see patients' heart rate dip down, but it comes back up. It's just that initial response. So just kind of be aware of that and mindful. And then you'll also sometimes see a vasovagal response with dizziness, nausea, vomiting. So again, another really good reason to always have someone in the room with you, or at least outside of the room readily available to be able to grab these things if you need them. You know, I didn't put it on the other slide, but in older practice, whenever I had first started here, we would actually just go ahead and pull atropine and have it at the bedside at the time of a sheath removal. I think that over time we get comfortable and we get used to not needing it, that we don't pull it, but it is a good practice to kind of be aware of, and honestly to just continue to do in your everyday care. Post-sheath vascular access care. So make sure that we're educating the patient and the patient's family that may be in the room regarding what this looks like. You know, these patients still need to be on bed rest post removal. They're still going to have the limb restriction in place, and we want to ease back into some of those things. We're going to make sure again that we're documenting vital signs, groin sites, pedal pulses, different things like that. Just like when a sheath is in place, your initial check should be every 15 for an hour, every 30 for an hour, and then hourly for that. Post removal is the same process. So every 15 minutes you're checking the sheath and documenting. After 1 hour you're doing it every 30, and then after that just hourly. Once bed rest is up, you can assist the patient with ambulation and reassess groin sites after activity and document. Further complications post sheath removal. Oftentimes you'll see these patients have some pretty gnarly bruising. It's completely normal. It's not really anything that can be avoided. These patients are going to have some bruising because of the pressure that we hold. It's just kind of part of it, but communicating that on the front end is always good, because some of these patients will, you know, the next day be like, gosh, what'd you do to me? And so it's nice to already let them know ahead of time that that's something that they should expect. And then hematoma obviously is the first complication, or the most common complication that we're going to see from these patients. It's seen during sheath removal and even after sheath removal. It's often noted to be some significant swelling. You may see some hypotension with that as well. Loss of sensation. We'll get into another complication here in just a few minutes that can also be an emergency. But, you know, just kind of making sure that we're monitoring these patients, continually checking those groin sites, and at the site that, or at the any sign that we think that there may be a hematoma present, that's an indication for you to hold pressure again. It's not going to do much good to just put, you know, a pressure dressing or different things like that on it. Manual pressure is the best way for us to be able to resolve that and to also keep it from happening. Additional complications would be a retroperitoneal bleed or a pseudoaneurysm. So with an RP bleed, you'll typically suspect these patients to have some presentation of flank pain, abdominal pain, back pain, unexplained hypotension, drops in their blood pressure again like we discussed. It can happen when the sheath's in place. It can happen whenever a sheath's been pulled. It's an emergency. It needs to be notified to the provider immediately, and you should be holding pressure as soon as you think that you're having these things happen. With a pseudoaneurysm, so it can form whenever an arterial puncture site fails to seal, blood oozes around the surrounding tissue and forms a pulsatile hematoma. It's got some tenderness and a palpable mass. It's typically confirmed with an ultrasound or Doppler, and then it's typically treated with thrombo injections, which we have to call people. It's additionally something that needs to be notified. It can be an emergency. All right, so now we're going to talk
Go back one slide. So the retroperitoneal bleed, for this purpose of this lecture, I think that's the one that you don't want to miss. And so in my mind, when you have vasovagal, that is something that is transient. You give them fluids, you give them atropine. After the pressure is let off, 30 minutes after the sheath pull, they start looking like a normal patient. If you notice that they're persistently hypotensive, they're like a little bit altered, they're not acting right, or they're all of a sudden tachycardic, more so than they were during the sheath pull or before, that's when you need to start thinking about a retroperitoneal bleed, and you should call the team and in your mind start thinking about what would I do to identify this. So, you know, when we get the call, we obviously evaluate the patient, but we send off like a stat CBC to see if there's been a drop. If there's been a drop, then at that point you're obligated to CT their abdomen and pelvis. You don't have to do a contrasted study for retroperitoneal bleed. It can be a non-contrasted study, and you can get your answer pretty quickly. But as you're kind of figuring that stuff out, just like having the atropine at the bedside, I would start them on fluids and send off the CBC in the labs as you're making the phone calls and things like that.
So now we're going to talk just a little bit about some pressure assistive devices that we often use. Some of these you all see in the ICU all the time, some of these maybe not as frequently. And then obviously you all are very much aware of these. I've got all of them up here as well, and we can kind of talk about them too. But First, we'll talk about the Safeguard. So it's typically a compression device that we use after a lot of our structural cases. See them in or on CTSU quite often. In the ICU, you'll see them every now and then, just not as frequently. It's typically used to assist in gaining and maintaining hemostasis for a femoral artery. There's two separate sizes. There's a 24 centimeter one, and then there's also a 12. The 24 holds 40 cc's of air, and then the 12 holds 7. These devices are not to be used in place of manual pressure. These are just to assist post-procedurally and different things like that to kind of assist. So, you know, this is not something that you're slapping on because you're concerned that there's still some oozing and different things like that. Again, manual pressure is going to be the gold standard in those cases, but these devices are used for short periods of time to be able to kind of assist with obtaining and then maintaining that hemostasis, like I've said. Typically these stay on just for a few short hours, and we're gradually removing some of the air from these devices as they're in place. With the Safeguard, TR band, and even the FemStop, these actually have a window in the area where the access site should be, so you're actually able to visualize what that looks like and readily assess for any kind of bleeding while you're removing air. So with our Safeguards, you know, typically these are in place at times whenever patients are on a bed rest for about 6 hours post-procedures. And over those 6 hours, we're starting to remove some of the air in those devices, whether that be, you know, a few cc's every hour to, you know, gradually over the last 3 hours of their bed rest, just to kind of get it completely flat. And then after that, they're removing it from the skin. It's not something that needs to be stayed on. Normally what we'll do is we'll redress with a pressure dressing and some gauze after the bed rest is complete. With the TR band, it's similar, but this is used typically for radial access. So you'll see this post-cath in a lot of patients just on their wrist. Sometimes you'll see more than one in place if we've had an issue with being able to you know, get manual pressure or hold manual pressure the way we need it. Again, these TR bands, I think the max that they hold of air is close to 18, but typically the max that you'll see around this is 12. With these devices, they're going to be in place for a few hours as well, but you're going to gradually start to pull air out of them over the next several hours, and you're going to monitor that site for any bleeding. If they're continuing to have some oozing, you're going to keep some air in, and then again continue to gradually pull off as you're able to note that the patient's not having any more active bleeding from that site. The biggest things with all of these devices is that we're making sure that we're still checking pulses, we're still checking cap refill. The last thing that we want to do is cause anyone to have some vascular demise because we've left these in place for too long, that we've caused further complications. We don't want to do any harm in these patients by any means, and so sometimes we can be slightly negligent by not checking these and just, you know, giving them full credit for doing the job that they're meant to do, but we leave them in place for too long and we can cause further issues. Especially with the FemStop, you know, I was actually looking over some things last night online, and FemStop is like the gold standard for, you know, femoral pressure and all these things, but there's been a lot of times where we've seen patients have, you know, gnarly bruising from having these in place. There's been limb ischemia and different things like that because we're not using it efficiently. So with this device in particular, you know, it comes in a few different pieces. There's the gauze that goes around their body. It's connected through this clip. If you're not familiar with the device, it's best for you to get familiar before you need it. So I definitely encourage for you to come up here and look at it. I'm obviously going to give it back to Laura and she can take it back to the unit. So if you know other people who maybe haven't had a chance or an opportunity to use a FemStop again, it's better to use it now than in a, you know, emergent situation. Again, it too has a device cover on it on the back. It's a plastic piece. This isn't meant to actually go on the patient. It peels off, and then you'll be able to feel the soft silicone pressure device that actually has air that gets pumped into it for us to be able to hold pressure. If you have a FemStop in place, you need to be checking pulses at minimum about every 30 minutes in their feet, in their legs, different things like that. You need to treat it just like you would manual pressure. So, you know, the more frequently that you're able to check that and make sure that things look good. But this is just going to be used for assistance with manual hold. So you've had someone you've held pressure on manually for 30 minutes and they're still oozing, you know, then you can put this in place to kind of help hold pressure, because it's not realistic for you to stay at the bedside on someone's groin for an extended period of time in your workday. I know you have other things to do. But again, that needs to be something that's used with caution, not something that's just thrown around and used too often and not managed appropriately. Now, with that being said too, it's something that shouldn't be used for longer than a few hours at a time. You need to make sure that you're taking it off, that you're checking it, that you're releasing air from it pretty regularly, just to ensure that we're not putting any harm again to the patient or anything like that. Does anyone have any questions or anything to add on these devices?
I've seen, like, I came to ICU in the floor, and it is like the patient's up in a chair, and they've left the safeguard on, sometimes with air and sometimes without air.
Yeah.
And it needs to come off. Everybody knows I'm like a crazy dressing person, so like always, like, you know, and you'll probably get to that too, but like, look at your dressings, put dressings on, don't just leave that on, inflated or deflated, and have the patient walking around with it on.
Yeah.
The safeguard is, do you use safeguard? You don't use safeguard, do you?
I don't love them because I think it gives the nursing the wrong
Yeah,
impression.
so safeguards are like, they're technically under the umbrella of a compression device, but really, I use safeguards a lot because for large bore access, we make a skin nick, and so as you all know, you can have like capillary bleeding from like the nick site, and so that's really where the safeguard started to be used at Park West, like when we put Impellas in, or we put in 12 French sheets, and you had like a little bit of oozing from the skin nick, not necessarily arterial bleeding. Safeguards will not take care of arterial bleeding, and so they really are meant to be there for like a couple of hours, life pressure, and if you think you need to use the femstop, you need to call somebody.
The safeguard is really truly like trapped. So it is not gonna prevent a hematoma.
Yeah.
The problem with the safeguard is you really have to be checking for a hematoma, because if the arteriotomy itself is bleeding, the safeguard does not provide enough pressure to compress the arteriotomy. And so you will develop a hematoma under that safeguard if a safeguard is on.
I've never used a safeguard. I've used the femstop loads of time, but with the safeguard, the adhesive, when there's not an adhesive area on that section.
No, it's just the white mesh
just
portion of the dressing, and it's a one-time use. It's not to be, you know, reapplied or anything like that. Technically, all of these are advertised as a one-time use, and technically, like, aren't really branded to be reused. I know the femstop, you know, we've taken them off a patient and used them on that same patient again, but it's not necessarily ideal. The other thing that I will mention, because I've seen it a few times, and I've not necessarily seen it since this role, but as a bedside nurse, you know, there were times where we would have an RP that would be in place, and we would use a femstop, or a femstop would be used to help hold pressure for oozing around that site. As Dr. Negrado already mentioned, and Dr. Rahman, this is something that you need to call the provider about before you throw something like that on. You know, with the RPs, with the peel away sheath and different things like that, too much pressure can cause that to be impaired and can cause further issues. So a femstop shouldn't just be a Band-Aid because you're, you know, getting tired of changing a dressing or different things like that. If it's significant enough that you're having to frequently hold pressure, significantly, you know, change dressings often, different things like that, that's something that we need to be aware of so we can see what we need to do troubleshooting wise to fix that problem, rather than throw a femstop on there, because that could be something that can not only, you know, affect the vascular access of the patient, but it can impair the pump function as well if there were to be any kind of damage.
That's a good point, Sydney. I think that's the one thing also, like when, especially with an RP, that's the one time that you need to ask, and physicians should say this. So there's a repositionable sheath, and then there is a peel away sheath. And usually we will leave the peel away sheath in, which is a larger sheath. The problem with the peel away sheath is that you can fracture it and you can like crack it. And if that happens, they'll bleed like stink, like an RP type bleed. And so those patients cannot, like, you know, you basically have to immobilize them. And it's so fine if it's like if you think it's just for like a, you know, overnight or something, but it's something, you know, you definitely want to be careful with a femstop over a,
Yeah, you make the leg ischemic. I mean, that's the biggest. If you leave a femstop on for too long, like the leg will get ischemic.
All right, so again, we'll talk a little bit more about just some different closure devices or methods that have been used. I've already touched on a few of them, and a few of them we've really not seen in quite some time. So to touch on the ones that are not very common that we often don't see anymore are the two at the bottom, Minx and AngioSeal. I truly couldn't tell you the last time I've seen either of them used in our facility. And on the handful of times that I have seen it, it's probably been less than 5 that we'd actually use those. Now, PerClose is something that you often hear that we use pretty often in our patients, and it's just a suture-mediated closure system that's used. You don't necessarily need to know much more about it other than, you know, you'll see these oftentimes with impellas and impella removal. There's often a box that is taped to the impella that's, you know, labeled PerClose, and it's got all the tools and everything needed for those. You don't have to do anything with it. The provider that comes to manage the pump or to pull the pump is the one that's going to be using those, but you need to be aware if they're in the room. If they're not in the room, then you need to make sure that they're in the room for the patient if that's something that's in place. It should be noted in procedural notes if patients have these in place. So that's why it's so important that you're reading documentation. That's something that's not often transferred over to other notes. So if anything else, you know, make sure you're reading your documentation on your patients, know what patients have had procedures, what those procedures look like, and if these devices could be in place. That way you can prepare accordingly. Another device that I've, you know, not had the experience with as much, but it's something that you all should be aware of, is the flow stasis used with Inari. So anytime patients have a thrombectomy, there's oftentimes that they'll have this small device in place. It's small and white. I wish I would have added a picture to it. It's typically, you know, covered with a bandage or something underneath it on their groin site, but it needs to stay in place, I think 24 hours. An hour comes the following day to remove it. It's not something you touch or move, correct? Okay, cool. So again, just be aware of that. If your patient has that, make sure you're documenting that, make sure you're passing that on. And then we've already talked about it, but a quick clot or a thrombix, it's the impregnated gauze that oftentimes you'll see people use before a dressing with sheath removals, just to kind of help have more efficient hemostasis with some of those pulls and everything. It's available in urals on both sides of the ICU, so I'd definitely be familiar with where it's at, and then I'd put it into practice. I think that it's really beneficial. All right, so then last thing is just to talk about some impella removal specifics. Now, I want to preface this by saying that this can be provider specific. And so the more that you work with some of these providers, the more you can anticipate what they may use or what they may not use, but you can plan accordingly by that. I am slightly biased, so obviously I've done on here what I'm most familiar with in regards to whenever I'm present for removals. So supplies that you'll need for a general RP removal would be a gown, gloves, masks. It's good to have a good set of scissors. The scissors in the suture removal kit are not helpful, so like they're just general purpose scissors that are you know, packaged by themselves are ideal. 2 sets of hemostats, a large tegaderm, sterile gauze. With the hemostats, it's nice for you to have ones that are clean or technically sterile. This is supposed to be as sterile of a procedure as possible. So the hemostats that you've been using on your IVs for, you know, the last 3 days that have been hanging on the hook in over your sink are not necessarily ideal for this situation. And then for just purposes, like I said, with provider specifics, typically we like to use a CTX needle. You have to get this from Cath Lab. I do believe that Laura might have a secret stash available. You can cut that. Same thing, O-silk suture. It's not the sutures that we hold in our ICU. It's not the blue ones that are in our stock rooms. These are specifically held in the Cath Lab as well. So another good thing to kind of have on hand. Additional supplies that may be necessary, and I highly encourage face shields, additional chucks and towels, another patient gown. It's inevitable that things are going to get a little messy, and so it's nice to go ahead and plan for that. Again, thrombics can be helpful, additional fluids just in case, and then you can grab a suture removal kit. There's oftentimes some things in there that you may need, and you know, there's other providers who may not use the same or the same devices as what I've mentioned, so a suture removal kit may come in handy. Additionally, you know, there's oftentimes where you'll see with these patients come up a small piece of gauze that's kind of like off to its own, and it's typically dressed individually, and then around the dressing may be the general dressing, but it'll have a big label on it that says purse strings don't cut, all of the things. You know, a few years ago there was an incident where these things got cut, and that wasn't necessarily ideal. I'm sure Dr. Negrato can kind of touch on the importance of what these are in present, or why they're used for, and how beneficial they are. But it's a type of suture that's used to help, you know, obtain hemostasis after we remove some of these larger devices and different things. But the big thing to take away from it is that you don't cut it, you shouldn't touch it. It's a provider specific use, and so you just need to protect it at all costs. Make sure that whenever you have those in place, you're communicating that. Make sure that it's, you know, documented everywhere. Document it on the patient's leg. Make sure the dressing clearly states that. Make sure you've said that in report. Make sure, even if you're, you know, going off to lunch and someone's watching your patient, you mention that that's in place and that that's the purpose of it. So, because there's been so many times someone's like, hey, I'm going to go to lunch, and while that person's at lunch, someone's like, I'm going to clean up all this stuff, I'm going to change dressings, I'm going to be productive. And while that's all fine and good, you'd hate for something to happen and those get, you know, impaired or cut or removed, whatever, and then all of a sudden you're having to answer for that later on down the road. And then another type of removal tool that we'll use is a mattress suture that can be in place. Typically, these are used for a short period of time if there's some oozing and different things like that. These are not something that need to be kept in for, you know, 24 hours or longer or anything like that. This is something that will be very clear that we want removed in, you know, 6 or 8 hours, that you're wanting to check the site still, because this is a really tight suture that folds up the skin, and it can cause some skin damage or skin breakdown if we're not monitoring that area and keeping a close eye on it. If you've got a patient that's awake that has a mattress suture in place, they can often tell you that it's a little uncomfortable. There's been a few times I'll go upstairs to, you know, CTSU or things like that post-procedurally, and I'm checking on these patients and I'm going there to remove that. And if they've been up and moving around, or if they are, you know, awake and mobile enough, they can often say that it may feel a little tight. And so again, that's just something to be mindful of. People are at risk for breakdown with that, and so we need to know, hey, it's in place, but then also when the ideal removal time will be.
Okay, and most people know how I feel about this, and I don't think I have to worry about this with anybody in the room, but the reason for it, though, with her clothes is that there's two sutures, as most of you know. One is longer than the other, and one has a white tip. It's important to know which is which, because one of them is how you actually get the knot down to the vessel, and the other is how you lock the knot into place. And so if somebody cuts the sutures too low, I can't know which one's which. And so it kind of invalidates the whole reason why you have it there, because if you pull the locking suture before you get the knot down to the vessel, then you lock it in the track and you can't really push it down to the vessel at that point. So that's the kind of rationale for why.
Any questions?